So I guess I think this might be a little vlog with some rants. So I'm working on this case. It has nothing to do with coding or whatever. This is really more on the release of information. So the case that I'm working on, it's a 1 month stay. But the records that I received was just the ER notes and the discharge summary. So me as an auditor, how am I supposed to audit this correctly if I only have what happened in the beginning and what happened in the end? What happened to the middle? And that middle is about almost 30 days. So, gosh, with release of information, I think it's very important. And I've had this discussion with Sue Chamberlain on my podcast, but this is an example that with release of information, you guys need to read or you guys need to understand. I believe they just gave an abstract, whoever the release of information person was, but now I have to send this back. I'm like, dude, can I get a month's worth of records so I can review this properly? I mean, I could be mean and just edit, I do an audit just as it is, but, we have to keep our integrity as an auditor because I want to make sure that I'm reviewing everything. So a whole entire month of records is what I need. What I do want to, what I do want to share, because I know I've been talking about a lot of social media stuff, a lot of digital stuff. Where's the coding? Where's the coding, Brian? So what I do as a DRG validator, clinical validator, in my audits, I basically review charts and kind of validate, of course, the DRG and the clinical side, the clinical conditions. But I had one I do want to share, so I might do this frequently. I do have one that really caught my eye where I had to correct the procedure code, the ICD-10 PCS procedure code. So this was a patient who had an ST elevation myocardial infarction. Patient presented with chest pain, positive EKG, akinesis on the echocardiogram, troponins elevated. I mean, there's no way of disproving that. The patient also had respiratory failure with respiratory distress, placed on BiPAP. The one thing that changed this was, with a patient who has a STEMI, they emergently go to the cardiac catheterization room, and I'm sure they're going to have a stent or whatever it may be. But this case, this patient had a stent, of course, but then also an atherectomy, where in the coronary artery. And unfortunately, the case that I had, the thrombectomy portion was coded with an approach of open. So for PCS, I'm sure this also falls under CPT. The approach is very important. So out of the full list from the cardiac catheterization report, all of them showed, that they did a percutaneous approach, except for this code. This code really stuck out like a sore thumb. And if you're an auditor and you're looking over the DRGs, the list of diagnoses, the list of procedures, you can take a look at it if you're experienced enough. And I'll probably show you it, how I look over some things and I'm like, okay. And without even looking at the medical record, you can determine what's going to happen or what you need to validate, what you need to look for. It really sticks out like a sore thumb. So this case, all the procedures were percutaneous except for the atherectomy. And the atherectomy was coded as open. So I looked at the report, I validated the report. They went through the femoral artery, and I didn't see anything. When you think of atherectomy, you have to, an open approach, you have to, do a sternotomy, you have to open the chest. None of that was there. So it was a change. So I had to, write up a letter and say, hey, this is supposed to be, a percutaneous approach, not an open approach. And this changed a lot of things. This changed the principal procedure, which then switched over to a drug-eluting stent in the coronary artery. That became the principal procedure. And that changed the DRG, the surgical DRG, from a major thoracic procedure to a coronary stent procedure. And the change in relative weight was so dramatic. So if you're an inpatient, especially if you're coding heart procedures, which I have done. I mean, I've worked in a healthcare system with an open heart, bypass, cardiac cath. You know it. I probably did it. So, I mean, that's one thing that you have to watch very closely for. But I was scrolling through LinkedIn and saw an interesting post on elevated troponins and how there's going to be a upcoming code. I don't know what the code is for myocardial injury, which to me in its interpretation means elevated troponins. So when you think of elevated troponins, you automatically think a myocardial infarction. That's not the case. So anytime you see an elevated troponin with nothing else, you have to question, well, what's causing the elevation in troponin? What's causing that? What's the underlying cause? And in most cases, it's not going to be a myocardial infarction. You can have elevated troponins because of sepsis, trauma, inflammatory diseases, chronic kidney disease can elevate it, but not necessarily a cardiac issue. So in the grand scheme of things, you have to look at the whole entire record. If there's no symptoms, if there's no positive EKG, TEE, was cardiac involved? Those are things you got to look at before jumping the gun and assuming that, oh, let's query for a myocardial infarction. You're gonna be looked at weird. So the code for myocardial myocardial injury will be a CC. That's interesting because there's a specific code for elevated troponins, I believe, troponemia. So I'll be watching this because it's interesting from both standpoints, from a CDI standpoint, but also from a denial standpoint. The specific code I don't know, but again, it's going to be a CC. So I'm reviewing this chart. and remember, I think a few vlogs back I mentioned when you're auditing, you'll look at a set of codes and you look at it. And there tends to be, when you're auditing, a code that sticks out like a sore thumb. Let me give you this code description, okay? And I'm going to give you a bit of rationale why I think I should remove this code. First off, the code is 060.03. The description is preterm labor without delivery, third trimester. Preterm labor, or anything preterm in OBGYN guidelines, is anything before 37 weeks. So 37 weeks and I think 6-7 days before that, before 37 weeks is preterm, right? So remember the description, preterm labor without delivery. You know why this thing sticks out like a sore thumb? The patient had a C-section. So that constitutes as a delivery, right? So that automatically negates or devaluates that code. Preterm labor Well, preterm. Well, here's the thing. Preterm, right? The patient is she's at 39 weeks gestation. So why would it be preterm? The patient's full term. 37 weeks and above is preterm. 37 to 40 weeks is right at term. Anything after 40 weeks is post-term. So I don't understand why this code was assigned. Preterm labor without delivery. Patient is 39 weeks gestation and had a delivery. I don't know why people assign these codes. You have to understand, at least in OBGYN, gestational weeks of the mother and the baby. The reason why they came in for delivery. Is it induction of labor? Is it a scheduled C-section? Or is it spontaneous labor, spontaneous rupture of membranes, something like that? I find, for some reason, I connect more with OBGYN because I've done it as an inpatient coder. And of course, I've had 3 kids. So I followed my wife's journey in her deliveries. So I have an idea, right? As a dad, I understand OBGYN. I connect more to it. But yeah, that code, 060.03, adios. That thing needs to go. Coder assigned G8191, hemiplegia, unspecified, affecting right dominant side. Patient comes in with slurred speech, found to have a CVA. The documentation shows a past medical history of mild hemiparesis on his right side. The coder assigned the code G8191. The physical examination shows the patient is able to move all extremities. He denies any new weakness. So where's the hemiplegia?
MedicalCodingGeek.com